Now I'm scared to present knowing that I have people from the Ohio Consortium here to just, to be like, wow, where did he pull that out of? So, yeah, I mean, for those of you who know me, again, it's always nice to be among friends, I guess. My background is pediatrics. So the reason why I picked this article is I did treat babies with NAS. And that was really my well, it was one of my real first exposures to the opiate epidemic. As you know, once I decided to go into addiction medicine, then I started working with their parents. But there were certain themes that you found in the neonatal abstinence kind of world. One was how long is my baby going to be here, kind of things. The other thing was, and this is not pointing at anybody in this group, but there was a really kind of a disconnect between what the expectation was for a baby when they kind of came to the hospital. A lot of parents believed, or the mothers believed, that had they not been on buprenorphine, the baby wouldn't have ended up this way. Had my doctor did not prepare me for what was to be the expectation. We thought babies are born, if they're born vaginally, they're going to be here for 2 days. And you'd be like, no, it doesn't work that way. I wish it did. And that the baby could even be born in withdrawal as a general rule when they're on buprenorphine. So there were a lot of, and what were there things we could have done better along the way? So I thought this was a really great article, one, because I think it really promotes the kind of some of the awareness we need to do with our patients, some things we can do that I think are a little bit empowering, but also to kind of give them, I think, proper guidance. Because honestly, as I moved into providing, buprenorphine treatment for pregnant women, and I did that extensively in my Ashtabula clinic, there was a real push by several of my pregnant women to get off their buprenorphine, and I really did try to reiterate that is not best practice. There's risk associated with that, and that may not prevent, even if I get you to the lowest dose I can get you to safely, that's no guarantee that your baby will not have NAS. So honestly, I feel like this is a great article because it allowed me to say, yeah, and then you can say yeah too. So if yeah makes sense. So let me see. I got to get whatever Kay put on the screen. Let me move that around. So this article is from 2018. Again, it's called "Does Maternal Buprenorphine Dose Affect Severity Incidence of Neonatal Abstinence Syndrome?" Here's here are the authors of the article. This was done out of Washington State. So really the first question, I tried to use your question thing as a building block, is excuse me, is does buprenorphine dose make a difference in neonatal abstinence? I mean, again, back to my story. Yeah, I've had. Why do I think this is relevant? Is because I've had pregnant patients say, "Can I decrease my dose? Do I need to increase my dose? What is this going to have a long-term effect?" And again, we'll talk about this through the article. Um, and again, is there anything the pregnant patient should do to help with their baby? And there were some secondary conclusions that I thought were specifically helpful, specifically talking about breastfeeding in this age, in the neonates. So the way this study was designed, this was truly just a retrospective cohort study. Again, this was done in a large hospital system. They went back through the charts between 2000 and 2016. I believe they had, sorry, I want to say, what was the total number? It was like, I thought I wrote it down, 89 was the whole sample. I thought they did a kind of a nice job with the exclusion criteria. Again, this was merely looking at buprenorphine. This was not looking at the difference between buprenorphine and methadone. So they did not include methadone maintenance patients in this. They had to have a drug screen at delivery, ideally showing, that they were only on buprenorphine. They did, and if they had other substances in their system at time of delivery, they were excluded from the study unless it was THC. And again, patients that were negative for BUP on their urine. So the idea is, even if they were prescribed, if they were negative, they weren't included in the study. Interesting enough, I thought it was interesting that, yes, they did include THC. Mothers who were using THC, kind of their logic was it's legal in Washington. Of that 89 patients, there were only 4 mothers that were positive for THC. And to be honest, it was an even split. 2 were in babies that got treated for NAS, and 2 that were not treated for NAS. So it kind of became a wash in it. But So there was some substance use. And again, they looked at these. So they looked at these 89 included patients. They were a range anywhere between 2 to 24 milligrams. They basically were seen at one medical center. They were seen every 7 to 14 days. They all delivered at the same facility. Um, and basically what they showed is their BUP doses didn't change during that whole process. Um, Again, then the babies were monitored for 96 hours. So basically they were monitored for 4 days, which if I had to make an argument, I used to watch them for 5 days, but they did 4 days. And then they were doing what's called Finnegan scoring. For those of you who don't know Finnegan scoring, Finnegan was like the original writer of like neonatal abstinence, and he created a scoring system um, in the 70s, and it's what most of us have traditionally used up until recently. I know Akron Children's, specifically where I work, has moved to this eat, sleep, and console model, which doesn't use Finnegan scoring. But Finnegan scoring was really based on like jitteriness of the baby, not sleeping, poor feeding, skin excoriation, um, and based on that, it would generate a score. Typically in Northeast Ohio, my experience has been when you get to like a score of 18 and then you kind of make some general adjustments like feed the baby, diaper them, reswaddle them, and check them in an hour. If they're still 18 again, we typically started them on morphine. This actual study was actually using what I thought was even a higher score. They were using 24 with 3 consecutive scores of 24 to start morphine. So I thought they were a little more I guess giving in a way, like allowing these babies to look sicker for longer periods of time. Again, and then basically the same protocol was used to adjust morphine dose. There's basically, and then the weaning. Basically, typically what you do is the dosing is based on the baby's weight. You typically hold them there for, I believe they were holding them for about 24 hours. And then typically what you do, as long as they're stable and their scores are low, like below 8, then you begin to wean them by 10% every day, as long as they tolerate that. And that's typically how we do it until the babies are okay to go home. So that's pretty much what we use in Northeast Ohio as well. So what they were looking at when they designed the study is they were looking for primary outcomes. Did the babies require morphine? Yes or no, right? Again, what I would say is some of that bias in my mind for who got it, who didn't, is they really had a high Finnegan score to start these babies, which again, in my experience is we were using lower scores in Northeast Ohio to start these babies. So there's a little bit, you can again be a little bit biased when you do your scoring. Time to peak start of morphine, the peak morphine dose that the baby's needed, the total hospital stay for the baby, and days of morphine. So some of the independent variables then they looked at is maternal buprenorphine dose. Um, then they kind of, again, then there were the kind of the other covariates, the age, number of pregnancy, live births, prenatal visit, duration of buprenorphine prior to delivery, urine screens, tobacco use, and they looked at SSRIs as well. Excuse me. The neonatal covariates they looked at were gestational age, birth weight, breastfeeding status, if they were exclusively breastfed, and the APGAR scores. So with the design of the study, again, what they basically did is they just did a simple t-test comparing mothers' infant dyads requiring morphine and those who did not. They then kind of looked the NAS severity markers to see if there was so basically, did the babies need morphine, did they not? And then they kind of assessed the correlation with, was there a relationship with needing or not needing based on the buprenorphine dose, again, and the peak NAS, time to start morphine. They basically tried to see what connection they could make with this. They did correlation coefficients, confidence intervals, and regression analysis to look forward and backward as a stepwise procedure, which they tried to keep consistent with both. So I feel like, if I had to make one obvious thing, like I said, knowing that Finnegan's has a little bit of it's a little bit user dependent. I thought they did a pretty good job because they kept it to one facility. So theoretically, everybody was hopefully doing the same kind of scoring. They had enough experience with Finnegan scoring systems. When you go to outside facilities, it can, I can tell you from experience, especially working up in Akron, if your baby's at Maine Children's Hospital, they usually get lower scores than I do when I used to work in Mansfield, Ohio. It really does become a little user dependent. So at least this was one site that was kind of doing hopefully the same thing over and over again. So basically, using all those different dyads, covariates, they kind of looked at using t-scores. They basically found there were a couple things, and my next slide will kind of talk about this. But of all the things that the p-value seemed I'm blanking on the word, but of significance was one. If you look, is one breastfeeding. If you look at the two groups, so you have all the babies. You can look at the non-morphine group, which is about 50, or the morphine treated group was about 39. You can see the difference. If in the ones that required morphine versus not, there was a significant difference in the breastfeeding group compared to the ones who got morphine. There was a difference, again, which kind of makes sense. Non-morphine group kind of peak NAS. Versus the morphine receiving group, and a lot of times that kind of makes sense because again they didn't get sick, right? These were the babies that didn't develop more NAS symptoms. And then the other part is this hospital day stay was significant because again, if you make it through basically that 96 hours without having higher scores, then you didn't really qualify as an NES baby, right? Your baby was a normal, healthy child and didn't require any morphine treatment. So your length of hospital stay was shorter, right? I mean, because you didn't have to be there for 20 days if you didn't develop peak NAS. So again, the things I take away from this data, if you're going to really require morphine, again, this goes back to why I say about 5 days of monitoring, even though they said they were looking at 4 days. Here's some more different things really for the exclusively breastfed group. The other interesting thing they found about the breastfed group versus the non-breastfed group was a little bit interesting, only that the breastfed group tended to have a little bit older gestational age, tend to be a little more female. Didn't the comment didn't have any preeclampsia in that group, and less of these mothers were on SSRIs. Which to me, I wonder if that's and less tobacco. That was the other thing. And some of that, at least the tobacco and the SSRIs related to breastfeeding is, I found this repeatedly with my patients. If they're taking a substance into their body, they are very hesitant that they're expressing that in their breast milk and then giving it back to the child. So I wonder if that's, in my mind, a reflection of this kind of existing fear. Again, same thing why a lot of my mothers that I used to deal with did not want to breastfeed their babies because they're like, there could be buprenorphine in there. So I wonder if that's kind of a reflection. The preeclampsia, I have no idea, to be honest. But that's one of the things they found. So this is basically when you look at all the morphine group and the non-morphine group. Again, this is kind of another representation, just kind of showing you across the board of things like peak NAS, peak morphine, morphine start, and days of dose and days of morphine. You can, and then the bottom part of the graph is just the buprenorphine dose, and you can kind of see. If you see like these peak NASs, you can see it can be at lower doses. It really did not show. I look at this first one really more than anything. You didn't see, even at low doses, you could see just, in my mind, a large group that's above the line. It wasn't significant as a number in general. Same thing. I mean, all these things kind of just show you, as a general rule, it didn't seem to make a difference. These lines are not showing significant p-value kind of changes. So I guess we could stare at this indefinitely, but you can see it's all over the place. There's not like one truth in that line that kind of says, the dose it kind of pushes you anyway. So again, what does that table really shows? You know, excuse me, going back, I'm sorry, I'm all over the place on my slides a little bit, but basically when I look at the that original table, I should have put that ahead of time. The exclusively breastfed infants were more likely not, they didn't require morphine compared to the unbreastfed babies. Time to peak score, the morphine group got sicker over that period of time, but maybe not enough to hit the threshold to treat. That's basically what I took away from that. Hospital days, again, we talked about this, the overall hospital stay. If you required morphine, on average, most of these babies take about 21 to 28 days in my experience, and that kind of shows, they said their mean was about 20 days. And again, logistic regression across the whole sample found no other significant values. So Are these results significant statistically and clinically? Does this change anything I'm going to do or recommend? Um, statistically, I would say, I mean, it shows you, I guess I said yes to that just because I feel like, yeah, I mean, you can see that there's some clear differences, I think, in the groups, right? Between, I mean, more so when I look at the breastfed, but I think clinically, whether you want to say statistically, but clinically, what it really shows to me is that the BUP dose was not really the deciding factor on how we treat these babies, right? I mean, that's the truth. At the end of the day, the expectant mothers uh, tend to connect higher dose with severity of neonatal abstinence. That's been my experience. But again, it does not appear. We had lots of babies, who were. I'm sorry, I should have probably put this as a slide, but I didn't. I actually wrote it down on my little side notes. When you look at the incidence of NAS, it was overall there was about a 43.8% incidence. It was basically 39 out of these 89 infants. But just to give you an idea, and again, I should have made a slide out of this, but I didn't. When they kind of broke it down with 8 milligrams kind of being this threshold. So there was the 8 milligram and less than 8 milligrams and more than 8 milligrams. And what they found is of all these moms who were on less than 8 milligrams, it was about 48.5% incidence of NAS in those mothers, compared to when you looked at 8 milligrams and above, it was about 41.4%. So if you thought lower dose, well, there's about a 7% difference in incidence of NAS in the group. So it wasn't, again, a significant number. And again, to the greater conversation, a lower dose, if you looked at this study, and this is a larger study of buprenorphine NAS, these moms, the lower doses did not reflect less requirement for morphine in these babies. So um, again, now coming back to this slide, I would say to me, that's the important takeaway that I say clinically, is to encourage these moms to continue their doses and don't worry about kind of the idea of a lower buprenorphine is a better outcome for my baby. When we looked at lower doses, it did not seem to be a significant change. The other thing I kind of took away is we should be open on the average number of days of monitoring and treatment. I kind of threw this one in there because you saw that the group that got treated had like a 99. I can tell you right now, and this has been my experience as a provider for NAS, some of the insurances don't really like more than 4 days of coverage for these babies. They think they're ready to go home, and it's like horrific. I've seen babies come back because they basically we were told, and then they get home and they get sick. So if anything, I was kind of taken away, say, look, 99 days. Okay, we're talking five solid days of monitoring these bits. And that comes from personal experience of having the phone call with the insurance. What's the prior authorization phone call with the physician, physician to physician phone call where you're like, look, I know what I'm talking about. And he goes, well, I have this study. Well, I have this study. Okay, you need more time. So the other thing is we really should encourage breastfeeding. I know we talk about it all the time. What we know about breastfeeding, they've done several smaller studies in this, is there's very little buprenorphine excreted in breast milk. There is some. You cannot say there's zero. And maybe the fact that we are breastfeeding, we've always kind of drawn the conclusion is if the baby is having some symptoms of withdrawal, maybe that little bit of buprenorphine may make a difference. But we know at the bare minimum, especially as we look at these eat, sleep, and console models, the more we do to kind of gently engage the baby with their mother more than anything else, that may be enough to get them through this difficult period of time where we don't need to start them on medication. Doesn't mean they don't have some level of neonatal abstinence, but not enough that requires morphine treatment. So again, I think it's a good practice. So again, and this is a safe, and prescribing buprenorphine in general is safe. So that's kind of what I know. I'm happy to take questions. Like I said, I thought it was a nice study because I don't think it was the most complicated study I could have thrown at you or me, to be honest, as this is my first time doing Journal Club and I have the Ohio consortium on the phone for the babies. So let's have it. That's what I got for you today.